Okay, so we can start today's session, and extremely sorry for getting a little late. Uh, okay, good evening, Kakul. So today I've compiled 20 questions from pharmacology, a little bit more from general pharmacology, and then some questions. Good evening, Dr. Shamim. So some questions related to complications or drug interactions which are very commonly asked, right? So starting the session with very first question, where a 32-year-old male with pulmonary tuberculosis was started on rifampicin based therapy. 2 weeks later, his INR fall from 2.8 to 1.4 despite taking the same dose of warfarin. Now, which pharmacokinetic mechanism best explains this interaction? Now, this kind of questions are very commonly asked. Now, here the patient is on warfarin, right? And then he developed pulmonary tuberculosis, and then he was started on ATT containing rifampicin. Now, what happened? As he started rifampicin, INR, which was initially 2.8, dropped to 1.4. Now, what is the possible pharmacokinetic mechanism behind this? So, anyone would like to answer this? Now, here just few words about warfarin. Warfarin is an oral anticoagulant, right? So, it is an oral anticoagulant, and we give it for some thromboembolic conditions like pulmonary embolism or atrial fibrillation, right? So, it is given for thromboembolic conditions, right? And yes, Dr. Priya, you are absolutely right. So, what happens? Rifampicin is a microsomal enzyme inducer drug. Now, what does this mean? This means that if any other drug is simultaneously taken, the metabolism of that drug will be increased. So, increased metabolism of that drug. And once the metabolism is increased, it means decreased effectiveness of that drug. So, here what will happen? There will be decreased effectiveness of warfarin. So, here the drug in consideration is warfarin, and how we check the activity of warfarin? This is done by monitoring INR. So, if INR is more, that means there is more anticoagulation. That's the simple statement. So, now what happens when the drug is not acting more, especially warfarin? So, INR will also be on the lower side. So, that is how the answer will come out to be enzyme induction of hepatic CYP450 enzymes, right? So, it is an microsomal enzyme inducer drug, and therefore, any other drug which is simultaneously given with rifampicin, we have to increase the dose, otherwise the effectiveness of that drug will be reduced. So, that is a very important concept and has been asked many number of times, right? So, that is enzyme inducer. Moving forward to next question, again from a very important topic, has been asked almost in every exam every year. So, there is an elderly male who is having benign prostatic hyperplasia BPH, and now he is having acute urinary retention. Then he was given some drug which relaxes smooth muscles, especially in the bladder neck and prostate, and this drug is not affecting the blood pressure. So, what is the mechanism of action of this particular drug? So, very good Priya, very good Kakul. So, here the case is like elderly male with benign prostatic hyperplasia, and then he developed acute urinary retention. So, we have to give a drug that will relax the sphincter and that will allow the passage of the urine. So, what we will do, we will give a drug which will relax the smooth muscles or the sphincter, right. So, you can write sphincter in the bladder neck especially and prostate. Now, if you know the location of the receptors, these are alpha 1 adrenergic receptors. So, these receptors are to be blocked, and the drug which we give is tamsulosin. Okay. So, the drug is tamsulosin. So, yes, selective alpha 1A adrenergic receptor blockade. So, that is a very basic question. Yes, Kakul, selective alpha 1 blocker, and this is tamsulosin. So, it has been asked many number of times. Then moving forward to another question, a patient receives intravenous loading dose of phenytoin. Okay. Now, plasma concentrations rise disproportionately after small increase in dose, and the reason is that the metabolizing enzymes are saturated. Now, which type of elimination kinetics is demonstrated in this question statement? So, here the drug in consideration is phenytoin. Now, what is happening? The enzymes are saturated. So, if there is increase in if there is a small increase in dose, right. So, if there is small increase in dose, this leads to disproportionate rise in plasma concentration. So, this is a classical, yes, Dr. Shamim, very good. This is a classical zero order kinetics where a constant amount of the drug is excreted, and once the enzymes are saturated, even if we give small amount of drug, that will increase the plasma concentration excessively. So, that is a classical zero order kinetics, right. That is a classical zero order kinetics. Now, how it differs from first order kinetics? In first order kinetics, a fixed fraction of the drug is eliminated, right. And in zero order, a fixed amount of drug is eliminated. Clear? So that's very important. First order a fixed fraction, in zero order a fixed amount. Clear? So that's very important to remember, and especially if you find the word phenytoin, you can think of zero order kinetics, where if the enzymes, if they are saturated, any additional amount of drug which is then given, that will lead to disproportionate increase in plasma concentration. So that's zero order kinetics. Very good, Shamim. Then moving forward to one more very favorite question for exam setters, like a lady with bipolar disorder is receiving long-term pharmacotherapy, right? So she is taking some drugs since long. Now look at the complaints: polyuria, drinking too much, excreting too much of urine; polydipsia, drinking too much of water; and hypernatremia, increase in sodium concentration in blood. Then water deprivation test fails to concentrate urine, and also there is minimal improvement after giving desmopressin. So yes, I think everyone is right. Priya, Vikas, Shamim, everyone is right. This is classical lithium, right? So what is happening here? Young lady with bipolar disorder, and yes, we know that for bipolar the agent of choice is lithium. Now what is happening here? Polydipsia, she is drinking too much of water. Then polyuria, excreting too much of urine, and hypernatremia. And then more importantly, on water deprivation there is no concentration of urine. And on giving desmopressin there is minimal improvement, means minimal concentration. So what is happening here? This is a classical case of nephrogenic diabetes insipidus, right? So this is a classical case of nephrogenic diabetes insipidus, where ADH is secreted in the normal amount, but lithium makes the collecting duct insensitive to ADH. So despite having normal ADH, so ADH is normal here, but there is no concentration of urine. So it means the kidney is unresponsive. Clear? So that's nephrogenic diabetes insipidus, very commonly because of lithium. So that's how you can remember this particular concept. Next question: a young male presents with fever, headache, photophobia, and neck stiffness. CSF examination shows gram-negative intracellular diplococci, and then he was started on some IV antibiotics. What is going to be the primary mechanism of that drug? So here, firstly, we need to understand which clinical condition is being given and which bacteria is being discussed. Then we can think of a probable antibiotic which might have been started, and then we can answer what is going to be the mechanism of action of that antibiotic, right? So here, clinical presentation: fever, headache, photophobia, neck stiffness. This all goes in favor of meningitis, right? And then the bacteriological clues, gram negative intracellular diplococci, right? It means in pair. Yes, so this is Neisseria meningitidis, and for Neisseria meningitidis, what we need to give? We need to give ceftriaxone, which is third generation cephalosporin. And what is the mechanism of action of cephalosporins? Very good, Shamim, very good, Vikas. Yes, it inhibits bacterial cell wall synthesis by binding to penicillin binding proteins, PBPs, right? So that is how you will solve this particular question. So this question is about ceftriaxone for Neisseria meningitis, right? So that's how you can solve this. Then moving forward to next question, a patient accidentally ingests methanol, and I think everyone must be knowing that for methanol we can give ethanol as an antidote. So ethanol infusion is initiated in the emergency department. Now what is the pharmacological basis of this treatment, right? So known case of methanol poisoning. Now what we need to give? We need to give ethanol. So what is the pharmacological basis of this? So treatment, or you can say antidote here is ethanol. Now normally what happens, methanol is acted upon by alcohol dehydrogenase, clear, and then it will form toxic metabolites in the form of formaldehyde, and then this formaldehyde will be acted upon by aldehyde dehydrogenase to form further toxic like formic acid, and this is very toxic here. So what we need to do, we have to block this enzyme alcohol dehydrogenase, and for this we give ethanol, right? So there is a competition between the ethanol and the methanol to occupy or to bind with alcohol dehydrogenase. So this is a type of competitive inhibition. Very good, Dr. Priya, very good, Shamim. So this is a type of competitive inhibition. There is competition between the methanol and the ethanol to bind to alcohol dehydrogenase, right? So it means when ethanol will compete with methanol, obviously less amount of methanol will be converted into toxic metabolites, and therefore the toxic effects will also get reduced. So that is how ethanol, or sometimes fomepizole, can also be used, right? It can be also used, but classically we discuss always ethanol. So that's the reason. So competitive inhibition. So next question, a drug is administered intravenously and is found to have a volume of distribution of 180 liters in a 70 kilogram adult. Now which of the following best explains this finding? Now drug is given intravenously, it means 100% bioavailability, right? So but what we are seeing here, that there is a large volume of distribution. Now what is the reason for this? Why there is such a large volume of distribution? Because now if you look at the options, if the drug remains confined to plasma, obviously this will reduce the volume of distribution. If the drug is highly protein bound in plasma, this will again reduce the volume of distribution. So the answer is that drug is extensively distributed into tissues, and therefore there is large volume of distribution, right? So that's how you will apply the concept of this extensive distribution into tissues. So this will increase the volume of distribution. Okay. Next question. A patient with severe hypoalbuminemia develops toxicity after receiving usual dose of phenytoin. Now what can be the explanation for this? Now what is happening? Usual dose of phenytoin is given to a patient, right? But there is toxicity even with that usual dose. Now there is one statement given that there is severe hypoalbuminemia. It means there is very less plasma proteins, right? Now phenytoin is one drug which is extensively bounded to plasma proteins. Yeah. So normally it is extensively bonded to or bounded to plasma proteins. Now what will happen if the plasma proteins are less? Then the free fraction of the drug will be more to produce the effect, and therefore the effect will be too much. So low protein means free fraction of drug will increase, and this will increase the effect, and therefore there will be, you can say, toxicity, right? So the only fact is that plasma proteins are less, and therefore the bonding of the drug to the plasma protein is less, free fraction is more, and therefore effect will be more. So that's the basic concept for this particular question. So here the free drug concentration will be more, and therefore the effect will be more. So this is how you need to associate phenytoin, the concept of plasma protein bonding, especially with respect to phenytoin, right? So that's very important in terms of phenytoin. It is highly bonded to plasma proteins. So if plasma proteins are less, effect will be more, and even with the usual doses we can see toxicity in a given patient who is having severe hypoalbuminemia. Then a patient with septic shock is receiving continuous infusion of a drug, right? So there is continuous infusion of a drug, and after 5 half-lives, what percentage of the steady state concentration is achieved? So here the question is about 5 half-lives. So there are two ways, either you can just memorize it as such. Now I think most of you will understand what we mean with the word half-life. Half-life means the amount of drug will reduce to 50%, right? So this is half-life. Now we are taking 5 half-lives, so we have to reduce the value to 50% of the existing value with each half-life. So suppose if I take the first half-life, there will be 50%. Now second half-life, just half of this, right? So 50% means half. So for second it will be 25, third half life 12.5, half of 25, right? Then fourth half life will be something about 6.75, right? And then 6.25, sorry, 6.25, and then fifth half life will be again 3.12%, 1 to 5, right? So what you need to do, you have to simply add all these, and if you just add 50 to 75, then this is 87, so somewhere it will come around 97%. Clear? So by the end of fifth half life, the drug will be eliminated this much. Clear? So this is how you need to solve this kind of question. Okay? So this is 97%. So this is removed from the body with each half life. So the amount will be reduced to 50% of the existing, and that's how you can just keep on reducing the amount of drug from the body. So this much drug will be eliminated from the body by fifth half life. Clear? Next question. A patient with severe Clostridium difficile, which was previously known as Clostridium difficile colitis, is treated with oral vancomycin. Now, why we prefer this oral route? Right, so I think all of you can understand this is a classical case of pseudomembranous colitis. Clear? So this is a classical case of pseudomembranous colitis, and it is caused by Clostridium difficile. And now what we need to do, we need to give oral vancomycin. And I think if you know the offending drugs which can cause pseudomembranous colitis, so one is clindamycin, then cephalosporins. So long duration antibiotic therapy. So we are giving oral vancomycin. Now why we are preferring oral and not injectable route? This is because we want to keep the drug in the intestine for a large period of time, so that there is local contact. So the drug remains within the intestinal lumen, producing high local concentration. So that's the reason why we prefer oral as compared to IV. Okay, so that's pseudomembranous colitis, a very commonly asked topic. Then next question, a drug has an oral bioavailability of only 25%. Now, which of the following is the most likely explanation? So a drug has been given by oral route, and the one which goes into the systemic circulation is only 25%. So it means 75% of the drug is removed from the body. So bioavailability means this is available for action. So what is the reason why there is so less bioavailability? I think it's a very basic question. Yes, Dr. Shamim, absolutely right. There is extensive first pass metabolism, right? Extensive first pass metabolism, and I think most of you must be knowing what is this first pass metabolism, that whenever we give a drug by oral route, it is absorbed from GIT, taken to liver, and where it is metabolized. So some drugs are extensively metabolized. Very good, Imran, very good, Bache. So some drugs are extensively metabolized in liver, and this is known as extensive first pass metabolism. And whatever is remaining, then it goes to the systemic circulation, and that is known as the bioavailability after oral route. So this is the concept of first pass metabolism which occurs in liver, right? So this is first pass metabolism. So that's how you can correlate this concept. Then clinical trials, again very important from exam point of view. So during phase 1 of clinical trial, investigators primarily evaluate which of the following. So clinical trial, phase 1. Now what is checked in phase 1, what is done in phase 2, what is done in phase 3, and what in phase 4. Yes, Shamim. Now whenever we are planning to introduce a new drug, the very first thing is that we want to make sure that this drug is safer to the humans, right? So the drug should be safer. So the very first point is safety, right? So the very first point is safety, and therefore what we do, we give the drug to healthy volunteers under ICU facilities, so that in rare case if there is any reaction, the patient can be attended, right? So the very first thing is that whatever the drug we are planning to introduce should be safer, right? So therefore in this question, safety is the thing which is considered in healthy volunteers. Now once the drug is safer to human, then we move on to phase 2, and then phase 2 is about drug efficacy, right? So in phase 2 we go for drug efficacy, like in what dosage, what frequency the drug will produce good amount of response. So second is drug efficacy. Now third is, like whenever we are planning to introduce a drug, already some drugs are there in the market. So what we need to do, we have to compare the two drugs. So we have to compare the new drug with the already available drug in the market, and that is known as therapeutic comparison. Because if the newly developed drug is superior to the already available options in the market, then it is worth introducing this new drug. So in phase 3 we do comparison with the standard treatment or whatever the options are available in the market. Efficacy is phase 2. Now once we are confirmed that drug is safer, we have already devised, we have planned the dose, frequency, everything, and we have already determined this thing that okay, this drug is slightly better than the other available options in the market, then we will release the drug into market, right? So here the drug is released into the market. And then what is phase 4? Phase 4 are actually long-term studies, right? So this is long-term studies, and this is known as post-marketing surveillance. So we will study how the drug is interacting with other drug, or if there is any idiosyncratic reaction, like that. So long-term studies, right? So these are the 4 phases of clinical trials which you should know, because this is one very favorite question for exam setters. So here phase 1 is about the safety of the healthy volunteers. That's the phase 1. Okay. So this is phase 4 here. So this is how you should remember clinical trials. Then moving forward to another question, a patient with epilepsy, and he was controlled with carbamazepine, and then he started on combined oral contraceptive pills. 6 months later, she presented with unplanned pregnancy. Now, what is the mechanism? So, the lady is a known case of epilepsy, and she is well controlled with carbamazepine. Okay? So, this is controlling the fits nicely, but she also started oral contraceptive pills for contraception. Now, what is the reason that despite taking OCPs, the lady became pregnant? And yes, it's unplanned. So, how the lady is getting pregnant despite taking OCPs? Again, this is a very basic question. So, what is happening here? The carbamazepine is acting as a enzyme inducer and therefore metabolizing the OCP drugs, and therefore this is reducing effectiveness, and therefore the lady is becoming pregnant. Clear? Very good, Imran, very good, Kakul. So, the carbamazepine, it induces hepatic CYP450 enzymes, and therefore the effectiveness of OCP is decreased despite taking the OCPs regularly. So, this is a very important concept in clinical practice. Whenever you are prescribing 2 drugs simultaneously, just make sure that none of them is enzyme inducer or enzyme inhibitor, because it will affect the metabolism of the other simultaneously given drug. So, this is one very beautiful made clinical scenario to describe this phenomena of enzyme inducer activity. Very good, Imran. Okay, chalo. Next question, and here a 50-year-old male with chronic heart failure, and he is having reduced ejection fraction, right? So, heart failure with reduced ejection fraction. He is started on a drug that inhibits sodium glucose co-transporter in the proximal convoluted tubule. Now, in addition to lowering blood glucose, this drug is also reducing cardiovascular mortality and need for heart failure hospitalization. Now, what is the mechanism of action of this drug? So, most of the thing has already been defined in the question statement itself, that patient is a case of heart failure with reduced ejection fraction. I think all of you must be knowing what we mean by the word ejection fraction. So, ejection fraction is what? Stroke volume upon and diastolic volume. Okay. And in a normal person it should be around say 60%. So, whatever the amount of the blood which has been accumulated in the left ventricle at the end of diastole, around 60% of that should be pumped out of the left ventricle into aorta. So, that is ejection fraction. So, what is happening here? the patient is most probably a case of left ventricular failure and the ejection fraction is getting low. Now, what is happening in terms of pharmacotherapy here? He is started on a drug that is inhibiting sodium glucose cotransporter, clear, and this is SGLT, especially type 2, which is acting in proximal convoluted tubule, right. So, in PCT. So, this is the drug which is inhibiting sodium glucose cotransporter. Now, this drug is inhibiting like this. Now, if we think of the normal scenario, normally what is the function, what is going to be the function of this sodium glucose cotransporter? So, if I write it like this, sodium glucose cotransporter. So, it is promoting entry of sodium plus glucose, right. So, it is promoting, you can say, absorption, right. So, from PCT. Now, suppose if I am blocking this, if I am blocking this SGL2 T2 especially, what will happen? There will be no absorption, right. So, there will be no absorption and therefore, glucose will go into urine, that will be known as glucosuria. Then there will be loss of sodium in the urine, that is known as natriuresis. So, glucose will be lost in the urine and sodium will also be lost in the urine. So, the two terms glucosuria and natriuresis. Now, this part is important for diabetes management, but natriuresis, what will happen if the sodium is gone, then the amount of or the intravascular volume will reduce and this will reduce the preload. Also, there will be reduction in the afterload, that is the resistance. So, what is happening? Preload is reduced, afterload is reduced. So, this is helping in heart failure, clear. So, this SGL2 inhibitor, although it looks like a drug for diabetes, but it is also helping in heart failure. And what is the reason? By promoting excretion of sodium in the urine, it is reducing preload and afterload, and therefore, this drug, like yes, gliflozin. So, we can write dapagliflozin, clear. So, these are the SGL2 inhibitors, gliflozins. Very good, Imran, Vikas, right. So, this is inhibition of sodium glucose cotransporters in the proximal tubule, right. So, this is especially with respect to heart failure. Although gliflozins, they are discussed as hypoglycemic drugs, anti-diabetic drugs, but they are also useful in heart failure patient. So, that is very important to remember here. So, very good Vikas, very good Imran, Priya, absolutely right bache. So, this is gliflozins. And anti-diabetic drugs are always very favorite for exam setters. So, please try to read in detail mechanism of action, interaction, side effects, definitely they will ask you. Then moving forward to next question, a lady with rheumatoid arthritis is taking methotrexate for around 8 months. Now, she is having painful oral ulcers, she is having fatigue and pancytopenia. Now, which adverse effect of methotrexate best explains her presentation. So, the lady is a known case of rheumatoid arthritis on methotrexate for 8 months, and now some complications has come. So, there is painful oral ulcers, then there is fatigue and pancytopenia. Yes, I think if you know the mechanism of action of methotrexate, it acts by inhibiting dihydrofolate reductase, right? And this will cause folate deficiency. So, yes, it inhibits dihydrofolate reductase enzyme. Okay, so that's because of this. Now, painful oral ulcers, this suggests that there is development of mucositis. Fatigue, it suggests that there is development of anemia. And yes, if you are taking folic acid, you can say it is megaloblastic anemia. And pancytopenia, this can be because of bone marrow suppression. Clear? So, that is how you can discuss the side effect or adverse effect profile of methotrexate, which acts by inhibiting dihydrofolate reductase enzyme. Next question, a 55-year-old male stabilized on simvastatin is now started on clarithromycin for community acquired pneumonia. 5 days later, he develops severe muscle pain and markedly elevated creatine kinase levels. Now, which mechanism best explains this interaction? Now, here the person is taking simvastatin. Okay, so statins. Now, along with this, he was started on clarithromycin for pneumonia, community acquired pneumonia. Now, after this, what happened? There is severe muscle pain and raised creatine kinase levels. So, yes, very good, very good. So, previously we have discussed few examples of enzyme inducers, but this one is enzyme inhibitor, right? So, this one is enzyme inhibitor, and obviously when the metabolizing enzymes are eliminated, so there is less metabolism, and then there is less metabolism, it means more you can say activity or more adverse effects. And for statins, especially simvastatin, the side effect profile is myopathy, okay, or rhabdomyolysis. So, rhabdomyolysis. So, this is the side effect profile of simvastatin. So, since it is not metabolized adequately, so even the usual drugs, they are producing adverse effects like myopathy or rhabdomyolysis. Therefore, the patient is having muscle pain, increased creatine kinase level. So, this is a classical phenomena of enzyme inhibition. So, CYP3A4 inhibition and therefore increasing simvastatin levels. And here you should remember this belongs to the group, like especially the macrolides, they have this property. So for enzyme inducers, please remember rifampicin, and for enzyme inhibitors, please remember macrolides like clarithromycin or even erythromycin. So very good, Vikas, Priya, Imran, very good bachcho, right? So this is how you can, I think now you will understand this concept nicely. Now moving forward to a little difficult question. Now a patient is receiving MAO inhibitor, right, monoamine oxidase inhibitor, for refractory depression, and he developed some congestion, so he took nasal congestion maybe, he took some decongestant containing pseudoephedrine, and after that patient developed severe hypertension. So what interaction has occurred here? So a known case of refractory depression is being given MAO inhibitor. Now he took pseudoephedrine, and as a result of this there is severe hypertension. Now what is the reason why it is happening? Now actually what happens, MAO inhibitor. So we need to understand the mechanism of action of the two drugs. MAO inhibitor, monoamine oxidase, this enzyme is actually needed for breakdown of norepinephrine, dopamine and also serotonin. Clear? So this enzyme is actually needed for breakdown of norepinephrine, dopamine and serotonin. So obviously if we are giving inhibitor, we are increasing what? We are increasing norepinephrine, dopamine and serotonin. So the level of these neurotransmitter is increased. Now this patient is also started on pseudoephedrine. So what is the mechanism of action here? It acts like sympathomimetic. Clear? So it acts like sympathomimetic. So it is also increasing norepinephrine activity. So increased norepinephrine from here, increased norepinephrine from here, it is going to increase the sympathetic activity leading to severe hypertension. So both the drugs, they have same kind of activity and therefore their activity is added together, and this is known as pharmacodynamic synergism. Means they both are acting in the same direction, in the same manner, and therefore the ultimate effect is more pronounced as compared to the individual drug, right? So that's why very good Imran, very good Priya, this is pharmacodynamic synergism, because both the drugs are ultimately increasing the activity of norepinephrine, and that's why the blood pressure is shooting up. So that's a very good question. So next question, and again a very basic question, has been asked many number of times. A patient is being treated with clozapine. Now he develops fever and recurrent throat infections. Then lab evaluation is showing neutrophil count of only 300 per microliter. So what has happened here? So clozapine causing fever and recurrent throat infections, right? So obviously fever is because of this. So what has happened here, the neutrophil count is low, and that is agranuloside. cytosis. So that's a very, very good, Priya. That's a very problematic complication of clozapine, that it can lead to agranulocytosis, and therefore if we do absolute neutrophil count, we will get to know that yes, neutrophil count is extremely low, and therefore the patient is predisposed for infections manifesting as fever. So that's agranulocytosis, please remember, as a complication for clozapine. Then next question, a patient was on prolonged corticosteroid therapy and now he develops severe hip pain. And when MRI was done, there was some pathology in the femoral head. Now, what might have happened here? So, prolonged steroid therapy, very good Imran, very good Priya. Yes, this can lead to avascular necrosis. So, this can lead to avascular necrosis of femoral head. Right? A means without, vascular is blood supply, and necrosis is death. So, this is steroid induced osteonecrosis or avascular necrosis, you can say, because usually whenever we teach avascular necrosis for exam, we always give you some fractures like fracture neck of femur going into AVN, or fracture through the waist of the scaphoid, or fracture through the neck of talus. But this is one non-traumatic. Clear? So, this is one non-traumatic example of AVN of femoral head, which can come because of prolonged long steroid therapy. There is one more condition, Kaizen's disease. It can also lead to AVN, right? So, these are some non-traumatic causes of AVN which you should know. Then moving forward to the last question of today's session, a patient with atrial fibrillation is on warfarin, and then he develops pneumonia, and for pneumonia the patient was started on erythromycin. 3 days later he presents with epistaxis and INR is 6.8. Now, what could have happened here? So, again this concept we have already taken in many different formats. So, here the patient is a known case of atrial fibrillation and he was started on warfarin for anticoagulation. Clear? So, we just want to avoid any thrombotic possibility here. So, he is on anticoagulation, but at the same time patient also develops pneumonia, and for pneumonia he was started on erythromycin. So, now the patient is taking two drugs, warfarin and erythromycin. Now, what happens later? Patient develops epistaxis. Epistaxis, that is bleeding from nose. So, it means the effect, yes, very good Imran, you got that thing. Huh? So, this anticoagulation effect is now increased, and how it can be increased? If erythromycin will inhibit the metabolism of warfarin. So, the anticoagulation will increase, and therefore patient will develop bleeding, and if you will check INR, the INR will also be high. So, INR you can see here is 6.8, and in the beginning I told you high INR means high anticoagulation, and high anticoagulation means high possibility of bleeding. Clear? So, that is what is being given in this particular case. So, yes, the classical statement here is that CYP3A4 inhibition by erythromycin. So macrolides, if given with any other drug simultaneously, always think of inhibition of metabolism of that particular drug, and therefore high chances of toxicity even at the usual doses. So what you need to do in that case, in such a case you have to reduce the dose of that another simultaneously given drug, because if you give at the usual dose, no metabolism, the amount of drug in the body will be keep on accumulating, and therefore it can produce adverse effect. So in such cases we need to decrease the dose of the simultaneously given drug so that the side effects don't come. So this is the concept of microsomal enzyme induction or inhibition, and that's very commonly tested topic in exams, right? So with this we can end today's session, and I am very sure you must have enjoyed the session. So very shortly I will come up with one more subject. Till then, keep on studying. God bless. Good night.